Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
Well, welcome to our dental webinar series. Today we are blessed to have Dr. Peter Yaman. He's a clinical professor at the University of Michigan School of Dentistry in Ann Arbor. He has maintained a part-time private practice and teaching appointment for 23 years prior to joining the University of Michigan dental faculty full-time in 1999. Currently, is on the editorial board of the Operative Dentistry Journal, the Journal of Prosthetic Dentistry, and is a reviewer for the Journal of American Dental Association, as well as many other dental journals. He has authored numerous articles and scientific abstracts and has lectured in the United States as well as internationally on restorative procedures with emphasis on compromised teeth and aesthetics. Dr. Yaman is involved in laboratory and clinical investigation of restorative materials and aesthetic techniques. Clinical trials are ongoing to assess the reliability of caries diagnosis techniques using laser fluorescence and digital radiographs. Dr. Yaman, it is a pleasure to have you on Dental Webinar Series today.
Okay, so thank you for this opportunity. As you mentioned, I did practice for 23 years in Ann Arbor, and I was part-time teacher at the same time. So I was kind of doing both for quite a few years until I went to the school full-time, which has sort of been my last things that I've been doing. So today we're going to talk about trends in porcelain laminates and how they've kind of evolved over time. So let me just start out by showing you a typical example of a case. I'm just show you the before and after, so you can see some of the issues here, and then we'll discuss this case a little bit more in detail later on after we go through some of the basics related to porcelain laminates. So this is the finished case. So you can see maxillary mandibular laminates. Those are all laminates that were placed on those teeth. For the maxillary ones, we've gone back to the first molars and gone back to the first premolars on the mandibular arch. So as I said, we'll show this case in a little bit more detail, but I want you to look, as you see this presentation, I want you to keep looking at the junction of the laminate and the tissue and to see the tissue response. As you can see here, how that looks just very similar to what you would normally see in healthy tissue with natural teeth. And that's exactly how the tissue response should be with well done laminates and with good margin design. So let's start out by talking about indications for these laminates. So when they were first being used in probably around the mid 1980s, most of the modifications were really for maybe changing color of the teeth and so on, or maybe closing some diastemas. And now, as you can see from this list, you can use them to change teeth in terms of discoloration, close diastemas, reposition teeth slightly with these laminates. You can correct malocclusion to a certain extent, replace poor restorations or cover them up with laminates. And then obviously for aging patients, you can make their teeth look a lot more younger in appearance and improve the appearance in general for aesthetics, which has become a priority now for a lot of our patients, is the aesthetic demand for treatment. So if we look at the advantages of the porcelain laminates, one is it's porcelain. They're color stable. Porcelain will not change color, and that's one thing that patients need to understand is when you use porcelain, whether it's crowns or whether it's porcelain laminates, many patients will want you to make them look like A1 or even lighter, a bleach shade. That may work okay for somebody in their 20s or early 30s, but as these patients get older into their 40s and 50s, that type of color is really not natural looking. So it's, you know, it is on us to kind of explain that to the patient, make sure that they select a color that's appropriate for them and that going forward as they age will still be an appropriate color. Porcelain bond strength, when you bond porcelain to tooth structure, it's unbelievably strong system, much stronger than anything else that we have. Periodontal health is something that will, you know, you can see from these finished cases. Glazed porcelain resists plaque accumulation, and as long as it doesn't get scratched or you don't remove the glaze, it responds really pretty well in terms of plaque accumulation. So there's very minimal plaque accumulation, which helps for periodontal health. They resist abrasion. Obviously, we all know porcelain is a very strong material by itself. The porcelain laminates themselves are relatively fragile because most of the time they're only about 0.5 millimeters, maybe to 0.7 millimeters thick. So in terms of handling them, they're very fragile until they're bonded. Once they're bonded, they develop a relatively high tensile and shear bond strength to the tooth structure. They obviously don't absorb any fluid, so you're not going to see any discoloration as you might with composite veneers or composite laminates that you might place, which will absorb fluid and change color over time. And we can control the texture of the porcelain, can control translucency, control the color internally and superficially, and they have a natural fluorescence, as I said earlier, which is it's the best thing that we have to duplicate natural tooth structure. What are the disadvantages? Well, you have to cut the teeth. So once you've decided and the patient has decided to do a porcelain laminate, they need to understand that this is not a reversible procedure. There has to be some tooth reduction that's done. So you're really committing that tooth to something for the rest of its lifetime. The technique is sensitive. You need 2 patient appointments. You have to have good laboratory procedures, a good laboratory backup to produce the laminates that you want and desire for your patients. As I said earlier, they're fragile. So you have to be very careful when you're manipulating these laminates for try-in and for cementation. They can't be repaired. Realistically, if somebody fractures a laminate, you may be able, as an emergency, bond some composite on that tooth until you can bring the patient back to be able to remove the remaining portions of it and replace it. So there's really no good way to repair these other than a temporary repair using composites. And then obviously the cost. For most practices, at least in the US, porcelain laminates are just as expensive to do as doing an all ceramic crown. So there's really not a lot of cost savings for the patient. So if the cost is an issue, then maybe an intermediate thing to do for those patients that really are concerned about aesthetics or need to have some improvement done would be to do it in composite until they can afford to have it done with the porcelain, which is going to be a much more expensive option. So what are some of the contraindications? Well, for porcelain, we always say bruxism is a contraindication, which it is, because we know what happens with the opposing teeth when you put porcelain on there, although many of the newer porcelains now are not as abrasive as they used to be. So, but that is still an issue with the porcelains, that they may abrade the opposing tooth structure. The other thing you have to be worried about is that you have to have enough enamel remaining. So you don't want to expose dentin. And we normally think that maybe you want to keep dentin exposure to less than 30% of the overall surface that you're bonding to, because the bond to the enamel is really what we want, and that's going to give us the longevity for these porcelain laminates. So the other thing that we need to think about is you have to be able to etch the enamel. And I'm going to show you, I think in the next slide, what we have to be concerned about as it relates to fluorose teeth and what you need to consider. Fluorose teeth are a perfect indication to do porcelain laminates, but we sort of have to alter our etching procedures to make sure that we get good bond to that tooth structure with when the teeth are heavily fluorosed. Dark teeth, tetracycline stained teeth, those become a little bit more difficult because as the teeth get really dark, the porcelain laminates, one of their big advantages is that they're relatively translucent. And so if you have dark underlying tooth structure, such as tetracycline stained teeth, you may not be able to totally get the aesthetic effect that you want because the darkness of the teeth from underneath may show through your porcelain laminate. So then you have to get involved in some other types of procedures to maybe mask the darkness of those teeth before you do porcelain laminates, or in some severe cases where the teeth are really dark, you probably don't have any other option but to go to a porcelain crown or some kind of a ceramic crown that will have enough thickness to it to block out the underlying color. And then for severely rotated teeth, that would be a contraindication. For minimal rotations, we can kind of deal with that with porcelain laminates, but the teeth are severely rotated. You really don't have much of an option to be able to correct that with porcelain laminates. So here's what I was talking about with the fluorosed teeth. If you have mildly fluorosed teeth, which usually have white lines and some opaque areas, you would etch those teeth the same as we etch normal enamel and dentin. If you have moderately fluorosed teeth, where they're completely opaque enamel, you need to double the etch time. If you have severely fluorosed teeth, which means that the surface of the enamel is pitted, or you have some areas of loss of enamel, you now need to etch those teeth for about 90 seconds for the etch to actually have an effect on the enamel to be able to give you a good bond. So these are things that not only apply for porcelain laminates, but if you're restoring fluorosed teeth with composite, you need to kind of follow these same guidelines in order to get a good bond to that enamel surface when it's heavily fluorosed or severely fluorosed. So you need to really worry about your etch times in those types of situations to make sure you get an adequate bond. So let's take a start on, we'll look at a case and go through this case step by step so you can see how we can manage these types of cases. This was one of our hygiene students at the school. Actually, he was a male hygiene student, and you can see the difference in color between 8 and 9. He was hit in the mouth with a baseball. He was a baseball player as well, got hit in the mouth. And number 9, you can see the left central incisor is a little bit more opaque, has less translucency than number 8. And the radiograph of that tooth actually showed that it was somewhat calcified compared to number 8, but it didn't require a root canal because it never became symptomatic. So this is not an unusual situation for an anterior tooth that may get damaged or traumatized. The tooth essentially is doing by calcifying a little bit, it's sort of doing its own endodontics. And this is what results in terms of the color of the tooth. They become a little bit more opaque and darker. So just kind of keep that visual in mind as you see what will happen once we place the laminates. So the first thing that we normally do with these types of cases is we do a diagnostic wax up. And then we just have a putty matrix of that diagnostic wax up. And that is for us to make a temporary, which I'll show you how that works in a little bit as well. So it's very important to do the diagnostic wax up so we can determine the size of the teeth, the shape of the teeth. In this case, closing those diastemas, are the teeth going to look too big? Are they going to be the correct shape for that patient? And so by using that diagnostic wax up and making temporaries for these teeth, the patient can then see roughly what the final laminates how they will look once they're done based on that diagnostic wax up. So it's a good diagnostic indicator for the patient. So if they think the teeth are too long, too short, they're not rounded enough, or they're too square, they can let us know that, and then we can make changes prior to making the final laminates. So it's very important that you do guide cuts. And these are just some burrs that are available that I like to use. These are from Brasseler, and you can see the ones that kind of are stacked with the 3 rings. One is a 3/10 of a millimeter depth cutter. The other is a 5/10 millimeter depth cutter. So For normal cases like this, where the teeth aren't severely discolored or not very dark, we normally use a 3/10 depth cutter, because by the time we reduce the remaining surface of that tooth, we're going to actually be removing a lot more than 3/10. So the only time we use this 5/10 of a millimeter depth cutter is, I don't know if you can see my pointer, this is a 5/10 of a millimeter depth cutter. The only time we use that one is for severely darkened teeth, where we realize we need to take a little more tooth structure off so we can have a thicker laminate to hopefully mask the underlying tooth color. We also recommend putting guide cuts on the incisal. And so the incisal reduction needs to be about 1.5 millimeters to 2 millimeters. So we would make an incisal cut of maybe about 1.5 millimeters or so, or maybe a little bit more than 1 millimeter. And then as you cut across the tooth to the incisal, you're going to reduce it the adequate amount. And so this is really highly recommended that you place guide cuts, because if you don't use the guide cuts, then once you start reducing the teeth, then you really don't know how much tooth you've removed. You have no guide to be able to tell how much tooth structure you've removed. Preparing these teeth is relatively easy because there's not much to do, as you'll see in the final preparations. But the guide cuts are very, very critical. So it's really important to do that. Whoop, went too fast. So how much do you remove? Well, as you can see from this, from these little charts here, when you do all ceramic or PFM crowns, you're removing 63% to 72% of the coronal tooth structure by weight. With a porcelain laminate, you're removing 17 to 31%, so significantly less tooth reduction. So this is something that you can point out to the patients, that when we do these laminates, yes, we have to cut your teeth, but the amount of removal is very minimal compared to how much we have to remove for all ceramic crowns and PFM crowns. So when you prepare 3/10 to 7/10 of a millimeter, I talked about 5/10 to 7/10 of a millimeter reduction. So 15 to 22% of the labial surface is exposed, will expose dentin. So everybody tells you, well, you don't want to expose any dentin. That's true, but in some cases we can't avoid it, particularly if you have some rotation on the teeth or down by the cervical area. If you're trying to place a 0.5 millimeter finish line down by the gingiva, you may wind up exposing a little bit of the enamel or the dentin down in that area, based on some of the literature that's out there. And actually, when you do these, you'll see yourself that you're going to expose some dentin. And as I said earlier, you want to just make sure that you have less than 30% of that dentin exposed, and that will still give you a good surface, a good amount of enamel surface to bond to. So you can see here from this that the guide cuts that we're talking about are going to give you a higher frequency of proper depth of preparation. So that's why it's highly recommended. And the burrs that I showed you aren't the only ones available to be able to produce these guide cuts. So endodontic complications, we know that for single crowns, 3% after 5 years, maybe 5% after 8 years will require endodontics. Porcelain fused to porcelain, or excuse me, fixed partial dentures, 3% after 5 years, and maybe up to 21% after 6 years will require endodontic potentially, because most of the time you're putting crowns on teeth, there's already been some previous restoration, there may be recurrent caries, there's a lot more tooth structure loss. So it is potentially a little bit more of a problem where you may have endodontic complications with a crown. With the laminates, 2.3% potentially after 5 years, and that's usually related to deep proximal composites that were on those anterior teeth to begin with, and not necessarily just from the laminates themselves. So they're relatively safe procedures in terms of endodontic complications to do these laminates, so that you can reassure the patients that that's not a problem, because many times patients will ask if you tell them that they need to have a crown placed on a tooth, one of their first questions is, do I have to have a root canal done? Yeah, not necessarily, but potentially you may after 5 or 10 years with that particular tooth. So here's the preparation. So you can see very little tooth structure. These teeth don't look a whole lot different than they did before we prepared them. And the finish line is just slightly subgingival, so we can hide the finish line. And we'll talk a little bit about the preparation design with the diagrams in a little bit. And then you want to make sure that when you get an impression of these teeth, whether it's for this or whether it's for crowns or any time you're taking an impression, you want to make sure that you have extension of impression material beyond your margin. Because then when the laboratory technician pours up their models to fabricate this, or if they're going to do this digitally, there's no question about where your margin is. So then you're going to be able to get back a really nice restoration that is well adapted at the margins, which is kind of critical, whether it's for this type of procedure or for any indirect procedure. So an impression is very critical. We're not going to spend time on that other than to mention that it's very important that you get a really good impression of these teeth that's showing all the details of the preparation. So how do we design these things? Well, the initial laminates that were done way back in the, as I said earlier, in the mid-'80s, did not require any incisal reduction. So the incisal was sort of done similar to what you see here with the photograph that says no incisal coverage. But in this type of a situation, you can't alter the length of the incisal edge. You can't modify the incisal edge. Plus, over time and protrusive, they may wear enough of the lingual enamel that then it will expose the margin and maybe chip that porcelain margin. So what you're seeing now is the other two incisal coverages, where one is a butt shoulder, a butt margin, where I have the red arrow pointing to that. And that's realistically now the way most people prepare the anteriors, is to place a butt margin. It gives you a couple of advantages. It's easier to fabricate that type of laminate for the laboratory technician. It also allows you to extend the proximal surface of the preparation into the contact area, or towards the contact area, because a laminate with a butt margin on the incisal edge will seep from the facial. Whereas if you have incisal coverage where you drop a chamfer down on the lingual, that laminate may need to seep a little bit more from the incisal, which then may not allow you to extend into the interproximal, because that would create an undercut. So that's kind of one of the advantages. It's a little bit easier, and it allows you to extend into the interproximal a little bit more if you have a butt margin. There's also literature out there to support the fact that that butt margin will give you a stronger laminate than the one with the chamfer down on the lingual portion of the tooth. So that's another positive for preparing the tooth that way. So how about the interproximal contact? Well, we prefer, whenever possible, to not break contact because that just creates problems to do that. And aesthetically, it's not a compromise as long as you can extend towards the interproximal to hide the margin without breaking it. It makes it much easier to cement these, particularly if you're doing multiple laminates, like 4 or 6 across the anterior. If you remove the proximal contacts and you get a little bit of shifting of the teeth, then when you go to cement the laminates, you're going to have to make a lot of adjustments on the proximal contacts, similar to when you do adjacent crowns, where usually the problem that you have is adjusting proximal contacts in order to allow the crowns to seat. So by preserving the proximal contact, we eliminate that problem, and we're not sacrificing the aesthetics. But I'll show you a little bit later that when we're doing laminates for diastema closure, we now do have to go through the interproximal contact and modify our preparation to be able to create the proper emergence profile in those situations. So temporaries are your worst nightmare for laminates, because they're difficult to do, they're difficult to keep on the teeth. And initially, when we first started doing these in the 90s and for a number of years, we would actually prepare the teeth and not temporize them and just send the patient home, because the reduction was so minimal that most people couldn't even tell that the teeth had been reduced. Well, it's gotten to the point now with patients are so concerned with aesthetics that there's no way we can get away with that anymore. So the other thing is by waxing the study model and making temporaries that kind of are going to reflect the size and shape of the final veneers or laminates, then the patient can see what they're going to look like before you place the permanent ones in case they need to make, they would like you to make some changes to the size and shape, as I mentioned earlier. So how do you temporize? Well, if you're only doing a couple of laminates, for example, 1 or 2 laminates, you can do a direct resin veneer. But if you're doing multiples, 4 or 6, it's much easier to do the temporaries. You can use a matrix like you see here on the slide from a stone cast. We can do a suck down. The putty is a little bit easier because then you don't need a machine to do that suck down. And the putty actually works really well to make these temporaries. So I will show you how we do that. And most of the time now we don't use acrylics. We use the bisacryl materials because they're a little bit more aesthetic and they look a lot better than the acrylics in terms of final appearance, in terms of shade matching for what the final laminates are going to be. So this is just a spot etch for 2 laminates. You can just spot etch and then put direct composites on there. What you have to do though is when you remove these to place the permanent laminates, you need to make sure that you go back to the area where you spot etched and you lightly remove some of the excess resin that's there, because you're going to get excess resin where you spot etched, and that's going to be a high spot. And if you don't remove that with a diamond prior to trying your laminate on, you may crack the laminate because this is going to be a high spot from the remaining resin that's there. So that's just one little thing you need to be concerned about. And that's just the direct composites veneers. So as I mentioned earlier, you can do it with a wax up and then do a suck down, duplicate the model, do a suck down with an OmniVac machine to be able to use that to make a temporary. This is not unusual, but we prefer to do it with the putty, as I'll show you in a minute. There are some cements. Kerr makes a clear Tempon material. It's actually, it's Tempon clear, but it does not have any eugenol in it, which as you all know, you don't want any eugenol on the tooth structure before you go to do your adhesive cementation. So the Tempon clear does not have any eugenol in it, even though it's called Tempon clear. So the idea of having it clear is the temporaries are so thin that if you use the whitish type of cement, the white cement will shine right through that thin acrylic or bisacryl, and it won't look very aesthetic in terms even as a temporary. So this clear material allows the underlying tooth color to shine through, so it looks a little bit more aesthetic for the patient. So this is the way we normally, this is the same patient that we are doing the reduction on. Using the Putty Matrix, we place the bisacryl inside the putty, seat it on the patient's teeth with no adhesive, with no nothing. And then we trim the excess off. As you can see the excess here, we trim that off very carefully with a Bart Parker, and we'll pop all that excess off. So at this point, in this type of a case, we've already taken our impression. So there's no reason for us to remove these temporaries. So these are put on, they lock into the embrasures between the teeth, and there's actually no cement to hold these on other than mechanical grab from the interproximals of the teeth. And then we go through with either with a Bart Parker or with a fine diamond and open up the embrasures. You always want to make sure that you open any kind of temporaries that are sort of tied together like this, whether it's for crowns or laminates. You want to make sure you open up these embrasures so that the papilla doesn't get suffocated. Because if the papilla gets suffocated for the 2 or 3 weeks, you're waiting for the laboratory to make these laminates, then what's going to happen is when you go to cement the real laminates, they're going to get some recession of the papilla, and aesthetically, you're going to compromise that patient. So this is how we make most of these temporaries. This is not an easy thing to do. It helps if you have somebody that's done this before that can guide you through it the initial time that you do this. So the other thing, so you can see here the finished trimmed temporaries. Minimal irritation on the tissue from the trimming, because obviously we don't want to traumatize the tissue and wind up having a problem with that after the temporaries are removed. So in order to get a nice appearance to these, you can polish them similar to the way you polish a composite, but you're still not going to get the nice gloss that you'd like to see. So there's two things you can use. You can see on the bottom slide, we can just use a product called Bisque Cover. And so that product, you can just paint right onto the your Bisacryl temporaries and light cure it, and you're done. You get a nice surface finish. If you don't have Bisque Cover, most everybody's going to have bonding agent. You can acid etch the teeth and then apply a bonding agent on the surface of those teeth or the temporaries and light cure it, and you'll get the same effect. The nice thing about the Bisque Cover is we don't need to acid etch the surface of the temporaries. It'll bond to the surface without acid etching. So this is what the temporaries will look like. You can see from the stone cast down below the original appearance of the teeth. Now you can see the appearance of the teeth that have been done as temporaries from the wax up that we had initially done. So now the patient can see these, can see the size of the teeth, the length of the teeth, and determine whether he's happy with the appearance. Obviously, the color determinant is something you tell the patient. We only have so much latitude with the color of the Bisacryl materials or our temporary materials, so they shouldn't get too hung up on the color, although we try to get that as close as possible with the materials that are available. Obviously, with the porcelain, we have a lot more latitude in terms of the color that we can have those final laminates produced. So how about placement of these things now? So the first thing you want to do is try each one individually, check the fit, check the margins, make sure all the margins are closed, and then you want to put them all in together. And most of the cement kits have try-in pastes. The try-in pastes are water soluble, so you can put these on and look at them, and the try-in pastes actually match the color of the cement that you're going to be using to do the final cementation for these laminates. So it gives you and the patient a good idea of what the final color is going to look like. So one of the things you want to make sure with whether it's porcelain laminates, whether it's anterior crowns, is you want to allow the patient adequate time to look at them and approve the laminates. Because we've had, in all the years we've been doing this, I think we've had, I know of at least one case where we cemented the laminates after the patient said they were all fine and they approved the color, they approved everything about them. We went ahead and cemented them, and then the patient went home, called us a week later and said she was unhappy with the laminates. Now, we don't know what happened, what changed her mind, or what caused the problem. The last thing you want to have to do is to have to cut these off and remove them. They are unbelievably difficult to remove. Essentially, what you do when you remove them is you get a bunch of diamonds and start cutting the ceramic, being very careful to not cut beyond the ceramic and overcut the teeth, which can happen because you kind of lose sense of where you're at, because it's very difficult to put guide cuts into the ceramic laminates. So essentially, you're trying to remove all the ceramic and all the resin cement before you retake your impression. So give the patient plenty of time to look at these and make sure they're happy with the shape, color, and so on before you go ahead and do the cementation to kind of avoid that problem. So the laminates themselves will come back from the laboratory. Usually they've already been acid etched with hydrofluoric acid. So then you need to silanate them, and then you go to your resin cement. The teeth themselves, you remove the temporary, pumice the teeth to remove any plaque that may have accumulated on the teeth, since there was no cement interface. Plus, if there is cement, you want to make sure you remove that. Isolate the teeth as best as you can, and then we etch, bond, and place the veneers. Now, in your try-in, when you do the try-in, if you feel that the laminate has been contaminated, or your laboratory doesn't do the hydrofluoric acid, you can then use 9.8, 9%. There's a couple of different percentages of hydrofluoric acid that you can use, and hydrofluoric acid etch the inside of the laminate, the integral surface, for about 2 minutes. If you don't have hydrofluoric acid, you can use your phosphoric acid. So, for instance, if they have been if the internal surface has been had hydrofluoric acid put on it, but you feel that it's been contaminated, you can use your phosphoric acid to clean the internal surface. You just need to leave it on a little bit longer because the hydrofluoric acid is not as strong, or excuse me, the phosphoric acid is not as strong as the hydrofluoric acid. So it takes a little bit longer for it to etch the internal surface of that ceramic. So there's ways to get around that. But you need to make sure that that internal surface is clean and the tooth surface is clean. Most of your cement kits, this is just an example of one, and most of your cement kits will have a light cure version, which is what the little these thin tubes are, and these are the dual cure versions of the cement, and this is a try and paste. So these try and paste are the same colors as the cements that you're going to use to cement the laminate. I prefer very simple cementation kits. I don't want a cementation kit that has 12 shades. I like to control the color of my laminate with the porcelain itself and not try to control the color or adjust the color with the cement. That is a very difficult thing to do, and most cases will not turn out very well. So you want to control the color of your laminate with the porcelain itself. And in most cases, I use a clear cement so that there's no effect from the cement on the final color of the laminate. So most of the cases that the one I've shown you already, and some of these other ones that I'll show you, they've all been cemented with a clear cement. So go through the cementation process. You get the teeth nice and clean. Temporaries have been removed. We get them isolated as best as we can. We acid etch the teeth. And when you acid etch and you rinse, always rinse up from the incisal towards the tissue. If you rinse from the tissue down, you may blow some fluid down onto the tooth structure, which you don't want from saliva. So always evacuate going up this way. And then you place your bonding agent on, and then spread that out on the tooth following the manufacturer's instructions. And this is very critical, as it is with any composite procedure or resin procedure. All of these materials are different. So every manufacturer has a certain amount of time they like you to, whether to rub the material in, put one coat on, put two coats on. You need to very specifically follow that particular manufacturer's instructions. So again, when you air thin this, blow the air lightly up from the incisal towards the tissue. Don't blow down, because again, if you're blowing down, you may blow some fluid, saliva, or whatever gingival fluid is down onto the tooth structure, which is going to contaminate that surface. So then we place our laminate in, and I would recommend doing only 1 or 2 laminates at a time. I know some people that talk about this in continuing education courses will say, well, let's go ahead and cement all 6 at one time or all 4 at one time. To me, when you do that, you're creating a composite bridge, which you then have to go through and cut everything apart and open up the embrasures and open up the spaces. So I prefer maybe 2 at a time, the 2 centrals, the lateral on the cuspid and the lateral cuspid on the other side, and be able to control my excess. So you put the laminate in place, we tack cure it, and then what I mean by a tack cure is we run the light over the laminate, around the tissue, and on the lingual for about 2 or 3 seconds. Once you do that, the resin cement becomes like cooked spaghetti, and it peels off relatively easily. So it makes cleanup really simple. So now I wanted to show you this because we're going to put the laminate on number 9. And you can see a little bit of blood here. There's a mylar strip in here. Fortunately, the bleeding is on the lateral side, not on the central side. If it was on the central side, we would have to stop, get the bleeding under control, and then go ahead and cement the laminate. So you want to make sure you don't contaminate any of the surfaces that you're dealing with. So here's the final cementation. Okay, this is post cementation. This is 14 days later, and you can see the improvement in the tissue compared to a little bit of trauma that's created from removing the excess cement. So here's the final picture, but take a look at the 8 and 9. 8 and 9, because of the translucency of the laminate, look exactly the same as his original teeth did, where number 9 is a little bit more opaque. So that was really our problem. That was a mistake that we made in not letting the laboratory know that tooth number 9 was slightly darker or more opaque. And this is what we call taking a stump shade. So you would take the shade of your prepared tooth and send it to the laboratory. Then they can modify their porcelain so that we'd have gotten the two porcelain laminates to look the same, even though the underlying tooth structure on number 9 is darker than number 8. So this is kind of something that you need to be aware of, and that we overlooked in doing this case. So this is his final situation with his smile. Yes, it looks pretty natural. So I think that turned out to be pretty good, even though there's a slight difference in color between the two central incisors. And there's his two natural teeth for comparison. So you can see the difference between his natural teeth, and you can see the same thing reflected in the porcelain laminates. That's how translucent these things are. So can you modify teeth that are rotated or overlapping? Yes, you can, but there's going to be certain things you need to be concerned about. Is you're never going to be able to adjust the gingival contour, gingival margins. As you can see, number 8, central incisor, number 9, central incisor, tissue levels are different. And when you do the final restorations, it's still going to be different, even though aesthetically this looks a little bit better than what we had to start out with. So this is kind of what some people refer to as instant orthodontics. And when you look at some of the literature related to that, one of the things that you need to focus on is that you have to have an optimal preparation. So normally we suggest, if you're going to do something like this and trying to reshape teeth dramatically, that you actually send the case before you do anything to the teeth themselves on the patient. Send a study cast to the laboratory and talk to the laboratory technician about what they think they can do laboratory-wise for these laminates, and if potentially it could be a problem if they can't produce what you think you'd like to see. So you need to make sure that most of the times what's going to happen is you're going to have dentin exposed in some of these situations. So it's going to weaken your bond a little bit. And I mentioned earlier, you're not going to be able to correct the gingival aesthetics. That's going to result from the malaligned teeth. And so those are things you need to talk to the patient about. It's a compromise. So if they're really concerned about the appearance of the teeth, if they're willing to accept the compromise, fine. If not, then the option is orthodontic treatment, and then potentially maybe put laminates on anyway after the orthodontic treatment to correct maybe the color or correct the incisal edges of the teeth or those types of things. But there is going to be a compromise in doing these types of cases without the orthodontics, and the patients need to understand that. So let's talk a little bit about failure. Short-term failure could be high spots in the preparation that causes porcelain fracture. Seating pressure. When you're seating these things, you don't want to push them on really fast. You want to seat them slowly and allow the cement to flow. So most of the cements that we use to cement laminates have enough fluidity to them that allows you to do that, but just seat them very slowly and tease them down until they're totally seated. You want to make sure that in your finishing and removing excess cement that you don't cause a lot of heat and friction to build up that may cause micro cracks in the porcelain, which is going to cause the porcelain to fail over time. And then usually occlusion is the problem that causes the most failure with these. So you want to make sure that you distribute the occlusal forces, protrusive, lateral, the way it's supposed to be on those anterior teeth, and that minimizes that problem. I can tell you that in the more than 20 some odd years that we've been doing these laminates, we've had very few failures, very few problems. I think most of the problems that we've seen are actually failures that have come off intact. And many of them were not our laminates. They were done somewhere else. The patients came to see us with the laminate in their hand. And that usually means that something went wrong with the bonding. Either the surface was contaminated, or the bonding agent was not applied properly, or the internal surface of the laminate wasn't treated properly for it to come off cleanly without fracturing. Long-term failures, one would be fatigue, where you have accumulated stress on the laminate, which results in micro cracks. And the other would be where you've made these laminates extended beyond 2 millimeters beyond the enamel, which means you all know that you don't want porcelain to be very thick by itself. Porcelain in certain thickness is very strong, but when it goes beyond a certain thickness, it actually becomes relatively weak. That even applies to porcelain fused to metal crowns, where you don't want a porcelain thickness on your metal that's more than 2 millimeters, because now that porcelain is going to be relatively weak. Cement dissolution, I really haven't seen that as much of a problem. Although if you do get a little cement washout, maybe at the cervical margin because it's contaminated, or something has happened to it on the lingual margin from the patient going into protrusive or lateral function, you can always refill that with some cement, or some, if you acid etch that area, put a bonding agent in, you can repair that using a flowable composite. Long-term failures, chipping at the margins. I think if you don't use a beveled margin, which is more susceptible to fracture, and use a heavy chamfer or use that butt joint across the incisal, that will eliminate any chipping or fracture at the margins, because your occlusal contact is going to be going up against the thick porcelain surface, which is going to withstand the forces a lot better. So let's talk kind of briefly about diastema closure. So this is one of the patients that I treated at the school, and she was in her mid-30s when she came to see us. And you look at a case like this, obviously your first option is say, go see my friends over in the ortho department and have them close that space or distribute the space as much as possible. And then we may have to veneer, depending on what orthodontics can do, we may have to veneer the teeth from 6 to 11 to distribute the spacing or close the spacing. Well, she didn't want to go through the orthodontics. Okay, I suggested then doing the 6 anteriors to be able to distribute that large gap. And she didn't want that either. She only wanted her 2 centrals done. Well, when you look at that, you say, whoa, if I try to put laminates on those 2 centrals with that big a space, those 2 centrals are going to look really big. So we went ahead, took an impression, did a diagnostic wax up, and it actually didn't look too bad in the diagnostic wax up. So we went ahead and proceeded with the case. Now, when you do a diastema closure, there's a couple of things you have to do. One is you have to drop your finish line subgingival, particularly in the interproximal area. Not so much on the facial or labial margin, but in the interproximal, you have to drop the margin subgingival so you can develop an emergence profile so that the porcelain comes up in a nice emergence profile and doesn't come up like a square. And so that's one modification. The other is you have to take your finish line in the interproximal a lot further to the lingual, again, for the same reason, to be able to develop that emergence profile from the tissue, and also to wrap this porcelain around the proximal of the tooth to support that porcelain, because you're going to have a lot of porcelain out here that will be unsupported if you don't do that. So this is what the recommendation is for these in terms of diastema closure. You want to make sure that if you, in this case, we weren't a lot, she didn't want us to do the 6 anteriors, so we were only dealing with the 2 centrals. But this is the way you would normally distribute your sizing. You would go this way a little bit from here, and then you cheat the lateral over and then cheat the canine over to close that kind of a space with 6 anteriors. The other thing you need to worry about is the angulations of these teeth to give them a better look. Well, that's fine if you're doing more than 2. We were only doing the two anteriors, and this is what it looked like when they were done. So there's her two laminates on 8 and 9, and you can see preoperatively what we had and what we finished with postoperatively. And the nice thing is, by doing the emergence profile the right way and dropping the margins subgingival, we were able to squeeze the papilla. We were able to squeeze this papilla and close that space in between the teeth, so we didn't wind up with a dark triangle. So these two laminates, I can tell you, because I still see her at the school, these have been in her mouth about 15, 16 years now, and they look just the way they look in this picture now. They'd look, if you were to see, you would never know that she had laminates on those two teeth. Again, look at the tissue response. Looks just like her natural teeth, the lateral incisors. And that's usually what gives away some of the restorations that we do, is not so much the color of the porcelain or the shape of the porcelain, it's the tissue. As many of you, I'm sure, have seen with porcelain fused to metal crowns, where you see a bluish halo around the margin, and that's kind of a giveaway as to what's there. So let's talk about this. Got a few more minutes yet. This is the case I showed you earlier, and this was done by one of my grad students. And this is a very complex case when you look at it. The patient had got mild tetracycline staining on the teeth, and I'm sure that's why these upper teeth were treated initially. But you can see all sorts of problems when you see this angulation of this lateral incisor. The gingival height of these teeth is not correct. So you've got a lot more problems here than just the discoloration. And you've also got uneven teeth on the lower. So obviously, first thing you want to do, diagnostic wax up. And you can see we've changed the angulation of the teeth. We've raised the gingival height of the central incisors, tried to get them to look the same as the canines, which is aesthetically, we're not going to get into a lot of discussion about that, is you want the height of the canine and the height of the centrals to be about the same gingivally, and then the lateral should be maybe about 1 millimeter or so below that line. And so that's kind of what you're looking to do. So the way we did this is we did periosurgery, crown lengthening on the teeth. And so you can see here, we've raised the tissue level around the central incisors. Probably should have raised it a little bit more, and then raised this one a little bit more. They didn't quite get up high enough with the tissue level. There it is after 1 week of healing. And here's while we're waiting for the upper teeth to heal. Normally, when you do crown lengthening, if it involves some removal of bone, if you talk to most of the periodontists, they will tell you need to wait about 6 months. Well, most patients aren't going to want to wait 6 months to have the treatment completed. So we normally wait about 12 to 14 weeks, which is about 3 to 4 months before we'll treat those upper teeth, because you don't want to manipulate the tissue after you've had crown lengthening that involved bone. So in the meantime, we started working on the lower. Now you can see with tetracycline stained teeth, what happens when you remove a little bit of surface of the enamel. The teeth become much darker. And it becomes much more important to take what we call a stump shade. And a stump shade will give the laboratory technician the color of the prepared teeth. So now, in this particular case, the patient really wanted white teeth. She wanted B1 teeth. And so we needed to inform the laboratory as to the color of these teeth. It helps to send them photographs so they can see it, but you also should take a stump shade, which is, you can see right here, we're doing that on the upper teeth. There's little shade guides that you can use that are available that are specifically made to be able to get a stump shade. So the lower's already been cemented. Now after the healing time on the upper, we go ahead and prepare the upper teeth. And there's the final laminates, as you saw earlier. And again, look at the tissue response. These just look like natural teeth. There's no way anybody can see or be able to tell that these are porcelain laminates, because the tissue response is so good. It would have been nice if these centrals were a little higher to be a little bit more even with the canines. Might have looked a little bit better, but compared to what we had to start with, excuse me, this certainly is a much better result. And you can see once we started doing this, the patient wanted us to go back farther on the maxillary arch and one tooth farther on the lower arch, back to the premolars on the lower. And those, again, you have to modify your preparations, which we don't have time to get into here with that. So there's pre-treatment and post-treatment, certainly a very nice aesthetic result. I probably wouldn't have chosen this white a shade myself, but that's kind of what the patient wanted for her final laminates. So this is what she started out with, and this is what she looked like afterward. So one last thing I want to talk about is everybody talks about the no prep veneers. So we did a couple of cases with this, and realistically, when you look at the no prep veneers, they have a limited application. So this is a patient that had composite veneers on her teeth, and the teeth were not prepared. So this is preoperatively. So when you look at a no prep laminate, they work on small teeth, because then you can make the teeth bigger with your laminate, so you don't need any reduction. They work pretty well at peg laterals. They work pretty well in areas where you have tooth to arch discrepancy and teeth that are undersized. It's also, fine for irregularly worn teeth or irregularly shaped teeth. If you have bicuspid extraction where the teeth are lingualized and you want to bring them out labially, then you can do this. And I think we all do this anyway. So if we have that type of patient, we don't reduce the teeth as much as we normally would for a normal laminate. If the teeth are tipped to the lingual, we're not going to reduce a lot of the tooth structure. We may just put a finish line on, which is essentially what we did in this case. So there's the teeth with the preparations. You can see it's almost nothing. We removed the composite from the teeth, and then we just put a finish line around the cervical, just so the laboratory can see where we're at, and that we wouldn't wind up with a bulk of margin at the gingival area if we reduced it to create a little bit of a finish line. So when you look at this, that's the provisionals and the cementation process. When you cement, this is plumber's tape. It's very thin. It actually works really well whenever you're doing any bonding, so you don't bond to the adjacent teeth. It works well for cementation of laminates. It also works well if you're doing diastema closures using composite, so that you can build up the height of the teeth, and then you can remove this and go on to the other teeth. So it's a nice way to isolate. You can use a mylar strip, but these are a little bit thinner than a mylar strip, so it doesn't interfere as much with the contact area. And there it is post-operatively, the porcelain laminates done as with minimal prep, other than a little bit of a finish line down at the gingival area. And you can see these teeth are a little bit tipped to the lingual. They're lingualized a little bit. So being able to add porcelain out here on the facial surface is not going to affect their appearance and not going to make them look too bulky without the tooth reduction. So in this particular case, in cases similar to this, the so-called no prep veneers work pretty well, but we certainly recommend that you put a little bit of a finish line at the gingival margin, so the laboratory technician can see where these are going to end, and you'll have a little bit better response from the tissue, instead of just putting something there that's going to be a little bit bulky, and you get a little bit poorer tissue response. So I think, Uvo, that's all I have. This is it, the post-op, pre-op on the bottom down here, and then the post-op with the porcelain laminates. So Uvo, I think this is all I have. I know I went through that kind of rapidly to get it done in an hour. But thank you for the opportunity, and I hope that was informative for everybody.
Thank you so much. That was really. Do we have any? If you have any questions, we'll be ready. Dr. Srivastava, do you have any questions?
Sorry, yes, can you hear me? My internet's not working very well today.
Yeah, I can hear you. Go ahead.
Okay, thank you so much for this amazing lecture, Dr. Yaman. Really do appreciate all the wealth of knowledge that you've shared with us. I have two questions, actually. One is related to the no prep veneer concept, right? And I have seen so many of those even when we're talking about no prep veneers or laminates for peg laterals, I have so many times seen patients walk in with gingival inflammation right around those, just because there's absolutely no margin there to have the veneer rest against. So what is your experience with that? And then I'll come to the second question.
That's why, as I said, we prefer, even for a peg lateral, we'll put a finish line on it. We'll prepare the area down at the margin just to create a little finish line, create a little room for the margin, because otherwise, as you said, you're going to wind up with a bulky margin. Tissue is not going to respond very well to that. Tissue always does not like bulk. If it's under contoured, tissue will tolerate that much better than any kind of a bulky margin. So that's why we always prefer to do at least a little bit of a finish line to minimize the amount of bulk that's going to be at that gingival area and to not compromise the tissue.
Yes, exactly. I mean, I concur with that. So the issue being the way the no prep laminates are marketed, it really does give the impression to so many people so many clinicians who are providing it to not be doing that. I mean, I don't know as a specialist if there's a way around for me to be telling general dentists and that this is not the right way to be doing it with absolutely no finish line whatsoever. But the marketing has actually taken it there.
You're absolutely correct. It's all really about the marketing to tell the patient we don't have to cut your teeth, and there's no anesthesia required. There's no this required, and it's a reversible procedure. So it's similar to doing a composite type of veneer. If you take, and I did, if you take the Lumineer course, and I don't know if they're still doing that anymore, but they will tell you that in a lot of situations, what they like you to do is take get some casts of the patient and send it to their lab. And then the lab will indicate on the cast where they would like you to reduce. So their advertising does not match what they really want you to do. So they really want you to take impressions, send it to the lab. They will indicate where they think you should do some reduction. And based on that, that's what you do with the patient before you send an impression and take an impression and send it in. So the marketing is a little bit different than reality.
Right. Dr. Yaman, another question I have seen some very good, long-term veneers that are very, very stable in the mouth. The more common problem that I see that's happening, even with some of my own cases and some patients that I'm seeing that have been treated elsewhere, is just at the margin of the veneers. And, when we're trying to bury especially in the contact areas, so the concept about, not going lingually enough when you're trying to prepare the contact area, sometimes I'm starting to see staining right at the margins. Again, depends a lot on the patient's dietary issues and whatnot. So what do you do to prevent from happening?
That goes back to one of the diagrams that I showed about how we prepare the laminate with the butt margin on the incisal edge. And then we extend way as much into the proximal as possible without breaking contact. And so we may actually have a little wing that goes into the interproximal slightly below the contact area. And that way, if the laminate heats from the facial, that works really well with a butt joint. And that hides that margin. And we really have not seen much of a problem with discoloration on the margins of these things. I don't know if it's maybe because the patients are the type that don't accumulate it, or patients become more focused on their hygiene when they have these aesthetic things done, that they become a little more concerned about their hygiene and a little more meticulous. But that has not been an issue with us in terms of seeing staining. And it may be because we consciously really hide that margin in the interproximal without breaking the contact.
Okay. Well, I actually just saw a patient last week who had veneers done more than 20 years ago. And that patient, of course, has had some gingival recession, just physiological, I would say, across the arch. And that's where, you started to note very clearly how the staining was. But of course, it's a really long-term treatment.
For that one last thing, for that, if the laminates are still really in good shape, and if the patient doesn't mind that maybe there's exposure to that gingival margin, you can essentially air braid those margins and then repair them with flowable composite, kind of hide the discoloration. But you're going to see the difference, obviously, with recession. You're going to see the margin.
Right. Well, thank you so much. Thank you so much for the amazing presentation.
Thank you.
All right, thank you. I got about 4 more questions here. I will let you go. I said, how good is with patients with incisor hypomineralization?
Hypomineralization?
Yes.
That shouldn't be a problem. I think, once you reduce the teeth, depending on how deep the hypomineralization is, sometimes it's just on the surface. And when you do the tooth reduction, you're going to go down to decent tooth structure, and you should be able to bond to that without too much trouble. So the main thing would be, I don't think it would affect the color very much. I'm more concerned about dark teeth than I am on teeth that are hypomineralized, which tend to be a little bit on the whiter side.
Okay. All right. Someone was asking about, so that was Dr. Naboya. She's calling in from the United Kingdom. We have Duval from India saying, do you use dual cement, dual cure, or light cure to lute your laminates?
Yeah, initially it was all done with light cures because of the amine in the resin that changes color over time. That's sort of been taken care of a little bit right now with the manufacturers. It's not quite as much of a problem where you get a color shift over time with the dual cures, but we still prefer to use the light cure cement just to eliminate that problem, the potential problem of a shift in color, which you're not going to get with the light cures, but maybe potentially there with some of the dual cure materials. So we always recommend using a light cure material. And since the laminate is so thin, the light will penetrate through the ceramic with no problem and light cure it adequately with no trouble. So you really don't need the dark cure to do that.
All right. He said, can you throw some light on how to remove a veneer once it has been luted?
The only way you can remove it is essentially cut it off with a diamond. If it's been luted properly, the only way to remove it is essentially cut the laminate similar to the way you would cut tooth structure, just to remove it little by little, being very careful to not overcut the teeth, as I mentioned earlier, to not remove too much tooth structure, because it becomes difficult to tell when you're cutting ceramic, cutting cement, and then getting into the tooth structure. So you have to be really careful.
Okay. There's one question there about longevity. It says, what's the longevity of veneers? Most
of the current literature now is showing longevity of these to be 18, 19, 20 years with no problem if they're done properly and luted properly. Obviously, as the patients get older, as I mentioned earlier, you're going to get a color change for the patient's natural teeth, where they might get darker, plus patients as they get older, their teeth are darker. That's why I said, if you put laminates on that are way too light, like a bleach shade for somebody that's 25 years old, when they get to be 45, that may not look very good, just based on age. Okay. So, but the laminates themselves are right now, if they're done properly, they've got a good longevity.
Okay, nice. I have a question from Randon here. He says, can you reiterate on some of the challenges you face in making provisionals and how you overcome these challenges?
As I said during the seminar, the provisionals are your worst nightmare, to put a provisional on these. And what we found the way to do it is, as I showed in the presentation, is to do it with a Putty Matrix. You can certainly use the suck down Omnivac type of things, but the Putty Matrix seems to work a little bit better because it's pliable. And then we also allow the material to interlock within the tooth structure, and we don't remove it, and we don't make it and remove it like you would with a normal temporary, where you fabricate the temporary, remove it, adjust it, shape it, and then cement it in place. So these laminates, temporaries, we just, after we've done the preps, taken our impression, we just make the laminate directly on or the temporary directly on the preparations, and then trim the excess off, adjust the occlusion, and send the patient home. And they stay on by locking into the embrasures between the teeth.
All right. All right, Dr. Oduyemi from Nigeria, do you have any question? Your hand is raised. Dr. Oduyemi, you are able to speak if you want to. You can just turn on your microphone. I want to thank everyone for showing up today. We have folks from Ghana, from India, from Ethiopia, Nigeria, United States, from Indonesia. It's interesting. Thank you guys for showing up today. We have someone from Egypt, 2 people from Egypt, Tanta, professor of prosthodontics, Dr. Ayad. Thank you so much. I see you. Do you do IDS?
Immediate dent and sealing. Actually,
Yes,
we did a study with that, but not with laminates. We did a study with that with crowns, and we really found we were mainly looking for sensitivity issues and didn't find a whole lot of difference between immediate dent and sealing with sensitivity. There is literature that says immediate dent and sealing will give you a better bond for your final restorations. So I think based on that, I would probably recommend that if people are interested, yes, you can do immediate dent and sealing. I think that's not a bad idea.
All right, Dr. Boateng from Ghana. Are you guys? Do you guys do a lot of veneers in your school? You can speak if you want to. Your microphone is on.
So I'm not a student. I'm a practicing general dentist. We don't have lots of teeth. We don't do lots of dental work in Ghana generally.
I see. Okay. Anyway, I'll what you had. I have one last photograph to share here. Dr. Yaman.
Yeah.
This was a what would you have done? I think this was pretty similar to the case that you showed.
Yeah, it's very similar. Yep.
I mean, this was my first veneer and my worst nightmare. Well, every time I see the patient, for some reason, it would not bond. I don't know. I followed the manufacturers, in terms of what they gave. I've forgotten the what we used, but it just wouldn't stay. The patient will be back every other 2 weeks with some chipped portion of the veneer. We changed it from porcelain to the lithium disilicate, thinking that the bonding to that will be better, but it was a rough experience.
Yeah, I mean, this looks almost identical to the case I showed, except that you don't have any kind of tissue between the teeth. We had at least a little bit of a papilla, and the length of the teeth is different. Ours were relatively the same size. So, I mean, if you're trying to bond to this surface, I mean, these look like good teeth to bond to. So I'm not really sure why whatever you're putting on is coming off. So even if you do a composite to close the diastemas, that really should work, unless something the patient has some kind of habit that they're doing that's causing them to break or pop off.
Yes, I was just my first year practicing. I was so excited about like, okay, let me take on this, and just from bonding, I had to change it into I had to do a drastic decision to be able to solve this patient's problem. But so that was when I started that. I'm like, that's kind of dissuaded me. I'm like, why is this not bonding? But from what you've described, I guess following the protocol, I'm looking forward to taking on a couple cases that I have lined up. I guess you are not far away upstairs. I'll come. Right. I'll come look for you if I get into trouble. Thank you so much.
Happy to help. Okay.
All right. All right. Thank you. Thank you very much.